يا عاش ذيك انور، حافظ على الريكوردينج الله يخليك
ان شاء الله.
ابدا ينقطع. ومن ترجع يعني اذا صار عندك قطع بالنت وترجع لازم تعيد الريكوردينج. دون فيجر اباوت اوكي. هذه المحاضره حقيقه انزلها على اليوتيوب كما هي ان
اوكي ان شاء الله.
شاء الله.
قول لي استاذ غسان، هم عندكم اصابات جديده هواي مال كوفيد؟
ايش في كوفيد عفوا؟
اصابات هوايه هاي الفتره؟
قبل شهر كان اكو شوي عندنا اوت سيرج بس ما يعني ما they didn't put much emphasis on it.
ونحن شوي الفتره عبالك كل شيء هواي تصير اصابات، بس مو الكوفيد القديم، شكله ابنه هذا غير مؤثر.
وعليكم السلام.
استاذ عباس، اكو اصابات هوايه بالبصره؟
لا لا
مو هوايه مو
لا 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 ان شاء الله راحت بعد. اكو فلاونزا عاديه.
عمو احمد بخاطر برازيل واسمع بابا صباح ايه اوه شنو هاي برازيل واسمع بابا صباح ايه اوه
استاذ غسان تسمعنا؟
Yep, I can now. All right.
اوكي استاذ.
Shall we start إن شاء الله؟
ايه يعني احضر السلايد الاول استاذ، لانه هو الثاني قلت لك هسه العدد ممتاز. قلت لك انا هالمره تقصدت جروبات قسم مال باطنيه هم دعمتها فيدخلون. خلي ببالك ترى انا قبل 5 دقائق ردت ادخل ما كانت الروم مفتوحه يمكن.
صح.
ايه في دقيقتين نبلش إن شاء الله، بس عرض لنا السلايد الأول.
اوكي ان شاء الله. So here we are. Alright, so إذا بالإمكان لأنه هذا
أوكي أستاذ غسان.
I've lost some of my Google contacts, so if anyone care to continue joining us for in our future rounds, please just write down your email in the chat box. يعني حقيقة محتاج أحدث الجوجل كونتاكت مالتي فيما يخص هذا الجروب بالذات أقصد.
اوكي، يعني اليوم ان شاء الله الكل يعني ولو نزاحمكم انه ابعثوا لنا الايميل على الشات ان شاء الله. استاذ غسان نبلش؟
يتوكل على الله ان شاء الله.
اوكي بسم الله الرحمن الرحيم. Welcome everybody. Thank you all to join us. Today we are going to explain challenge thyroid function test by Ustad Ghassan Mashkouran. Really, this is very hot issue because a lot of pitfalls when you're dealing with this thyroid function test. Without further delay, let's get right into it. Okay, Ustad Ghassan, go ahead.
بسم الله. شكرا دكتور محمود. شكرا حضور. Well, happy to see you again yet another grand round. صوتي واضح here?
كلش واضح.
Right, so this presentation, it's actually an accrue of few cases يعني حقيقة راح نقدمها على جمعتها على مدار سنين في مختلف الأوقات، وحقيقة هذا البرزنتيشن هي constellation من أكثر من one presentation. So we're going to have about 80 slides and it's going to be pure, rather dry academic presentations. The topic will be addressing precisely, specifically immunoassays and its challenging, the challenge that it poses in our work. One of the articles I come across has this small sentence that I chose for tonight's topic, and I think it says it all, that immunoassays are no place for optimists. لأنه الحقيقة immunoassays are really poor assays in any way you look at it. ولكنها commercially available, they are affordable, and they have passed the test of time. يعني رغم عيوبها الكثيرة فإحنا نعرف أن الناس أصبح يعني medical community is well experienced with it. So why we use immunoassay despite كل المشاكل اللي تسوي اللي راح أعرضها بهاي المحاضرة على قدر المستطاع، هو الحقيقة إنه الاناليte اللي we're trying to assess and measure is very small and therefore cannot be measured directly. It has to be combined with an antibody so we can capture it. Starting with the TSH assay. بعض هالمعلومات هي basics لكن فما راح نطول بها كثير. The TSH assay, as we all should know by now, is a sandwich assay. When you have a capture, usually, but not always, biotin-related anti-TSH antibody that captures, that's the biotin triangle here and the antibody here, that captures the hormone, and another lutetium-labeled signaling antibody. And once you have this complex of two antibodies, one of them is the detection and the other one is the capture antibody. This complex need to be captured by the solid phase, which is usually streptavidin. So this is how it works. Once you have this complex settled in the solid phase, it will produce a signal. The higher the signal, the higher the concentration of the TSH. Now, what I need to المحاضرات لازم يكون بها تحديث. This has been our strategies from day dot. What I can tell you now that the biotin labeled antibody has been modified over particularly the last few years. Most of the assays now are actually biotin fortified, and they are therefore, although يعني حتى انه برغم انه هي عندها الاساي ببiotin لكنه biotin resistance. So that's one thing we need. I'm probably going to throw out today. And the other assay has actually paramagnetic antibody. It does not have biotin, and therefore they are biotin proof. Now, the principle is sandwich assay, higher signal, equals higher concentration. While on the other hand, the T4 and T3 assays are competitive when you have an antibody against the when you have an endogenous or native T3, T4 competes with a labeled T3, T4 for the signaling antibody. So that's a whole different saga. And this cartoon here depicts this theory when you have, as it shows here, the T4 molecule get captured by usually biotin-related antibody, usually, but not always. So that's the biotin part of it. And the reason we use biotin because it actually has a non-covalent, يعني ما be electric charge. It's a molecular compatibility with the streptavidin solid phase here. Now the native T4 will compete with the labeled analog T4, and it's the reverse of the mirror image of the TSH signaling concentration equation. So the higher the signal you'll get, the lower the T4 concentration is. So the curve goes downward here. Now, the analyte, I'm getting into some technicalities here, لكن هاي technicalities مهمة الحقيقة. We have more than one way of assessing the competitive immunoassays. One of them is 2 steps, and the other one is 1 step. In the 2 steps, you have the native T4 dispatched from the binding globulin, thyroid hormone binding globulin, and it gets washed out. It goes through a washout phase, and then they will introduce the analog T4. This is the architect. This is where you get with the Abbott assay. And this technique, because it has a washout, it's less likely to have to be susceptible or less susceptible for any antibody interference. يصير بها interference لكن أقل بكثير من one step. In the 1 step, they have the T4 or labeled T4 analog modified, so it will not be. It would lose its affinity to the binding protein. بمعنى إنه labeled T4 مو native T4 ما راح يتصل بالbinding globulin. فهذا يعطيك شوية قراءة أو يعني يوفر على الانالايزر 1 step. لكنه هذا more reliable for antibody interference. The last technique, which is really not very popular, when they have a solid phase of T4 that competes with the native T4 for a limited number of labeling antibodies. So this is the conceptual depiction of the analyzers and how it works. Now, the different assays اللي نسمع بها الأبت والروش والسيمنز وما أعرف إيش حقيقة they differ in many ways. One of them use the 1 step, Roche, for example. the Beckham as well. The Abbott used 2 steps على سبيل المثال واللي هسه بيسمونه architect. The calibration of the assays are different, and that's why you see the normal reference range ما بين الأبت وبقية والروش. يعني كل assay إلى normal reference range لأنه الكاليبريشن مالته اللي يعتمد بالدرجة الأساس بالمناسبة يعتمد على the timing of dislodging of the antibodies from the binding globulin, or the capture antibodies from the time it captured the analyte and the time it produced the signal. It's a very subtle dynamics there, and the calibration is actually يعني حقيقة ما في company تعرف the calibration equation of the other one. It's very exclusive equations. And what I think is more important is the epitope target. Now, مثل ما وضحت حضراتكم الانتيبوديز the hormone, the analyte, is considered as an antigen, and the antibodies, the radial capturing or the signaling antibodies, it actually attracts it has an affinity to certain part of the antigen of the hormone itself. By that I mean, for example, the Abbott, this is just an animation of a simplistic animation of how it works. The Abbott antibody target this epitope, this part of the T4. The Roche, for example, targets the other side of the epitope. Now, these are different epitopes, and therefore the antibodies are actually different between one assay to the other. شنو هذا تأثيره على من الناحية العملية؟ إنه if there is any heterophile antibody interference with the Abbott signaling antibody, يعني حقيقة you look at it as if كتعبير غير دقيق, as an autoimmune when your antibody is directed against another antibodies. So if you have a heterophile interfering antibodies against the Roche antibodies, it will not interact usually with the Abbott and vice versa. وهذا شيء مهم الحقيقة في شغلنا. حبيت أخلي هذا الشيء. Now هذه دراسة قديمة قدمناها في أكثر من محاضرة سابقة, واللي تبين إنه the red square signals represent the TSH level and the T4 level by the Roche, while the blue circles represent the TSH and the T4 levels in the Abbott assay. You can tell that the Roche reads higher than the Abbott's because of the calibration method differs from one assay to the other. تأثير هذا على شغلنا؟ يجي المريض يقرأ عنده TSH يقرأ في وانت you trying to replace the thyroid hormone عفوا في قراءة يقرأ عندك 4 and you try to tighten up or increase the thyroxine dose حتى يقرأ 1 وما أعرف إيش, بعدين يطلع هو رايح على الروش وقراءة أخرى ومسويها في entirely different analyzer. So these are some of the subtleties التفاصيل المهمة في عملنا. Now, this is a very elegant study by Baloch, and حقيقة I invite you all to go through it, but it shows what it's so-called linear relationship between the TSH and the T4. الحقيقة it's not very linear. Now, with the TSH level on the y-axis and the T4 on the x-axis, you could see here that this is the area where both the T4 and the TSH within the normal reference range of each hormone. However, there is an area where while the T4 is still within normal range, the TSH tend to go high or low. That represents subclinical hypo and hyperthyroidism respectively. Right. Moving from there to the point in this slide, حقيقة, and I think it's imperative that we gravitize this information and implement it in our work, in our day-to-day work. A small change, subtle change in the FT4 can result in easily in a dramatic changes in the TSH. And if you look here, for example, the TSH of 9, often T4 of 9, which is the lower bound, الحد الطبيعي, lower normal reference range. If it drops to 8, the TSH can easily shoot up to 10. Normally في دراسات أخرى يعني قدمتها في محاضرات سابقة لحضراتكم إنه بينت إنه ال T4 variation for each individual varies by 1 point. بمعنى إذا كان ال TSH يقرأ عند أي أحد فينا who's biologically a thyroid 15, it can swing between 14 and 16. So that's the intra-individual variation for that particular person. وهذا ما يتوافق ويا statistically normal T4 normal reference range اللي يمثل 95% of the population. Right. So with that in mind, if we all agree that a subtle change in the T4 can lead to dramatic change in the TSH, then that will will be one of the foundation for our standardized approach. And the whole idea is to have a standardized approach. One of the main objectives in هاي المحاضرة إنه to have a standardized approach to TFT's interpretation amongst all of us. This is a case that I saw just 6 weeks ago of a young man who I radioablated his thyroid. And I'd like to draw your attention to this number. When the T4 was 20.5, the corresponding TSH was 0.85. When the T4 drops down by 1 point to 19, the TSH has gone up to 2.5, almost 3 times increase in the TSH. This is just a simple, maybe not very precise, conceptual depiction of this whole idea. And we really should take this into consideration. يعني we should not take it lightly حقيقة. وراح أبين في حالات أقدمها إنه كيف the physician interpretation of notification كيف انتبه الفيزيشن على ال T4 وأدى إلى تغيير كبير في المانجمنت. Now, one of the domains of tonight's lecture will be to go through the analytical interference with the thyroid function test. Usually, we think of the heterophile antibodies, the autoantibodies. I will not talk about monoclonal, but I will talk about macro TSH and the biotin, of course. Now, the relationship between TSH and T4 is almost a log linear or a seesaw linear relationship, almost. إلى أن توصل إلى مثل ما بينا بالسلايد قبله إلى الحد الأعلى من reference range, then this linearity can be lost. So when the T4 drops down, the TSH, as we all know, should go up, vice versa. T4 goes up, TSH goes down. لكن عندنا احنا high and high and low. And these cases, it's going to be at the core of this tonight's discussions. The concept that confounds all these readings is, all this pattern of TFTs is what's statistically normal is not always biologically normal, and I'll explain that in the next few slides. Now, when you have high and high TSH, high T4, these are the usual causes: interference, TSHoma, resistance of thyroid hormone, artifactual, psychosis, and please don't forget, 5% of the confidence interval range. The normal reference range لل-TSH وال-T4 على حد سواء represent 95% confidence interval, 95% of the general population, صح؟ بمعنى إنه 5% of the population will skew outside the reference range. بمعنى انه احيانا، وحقدم هذا الكيس ان شاء الله، انه احيانا يكون عندك التي اس اتش عالي لكنه هذا عالي بشكل طبيعي بالنسبه لذاك المريض. وكيف راح نعرف هذا الشيء؟ هذا this is another challenge. And low, when you have low TSH and low T4, of course, you look at the interference, possibility of sick eothyroid, and of course, central hypothyroidism. Now, interference related to the heterophile antibodies, which are antibodies to the immunoglobulin that we use in the assays, its prevalence is thought to be 15% at its max. بالحقيقة بدأ يقل أكثر وأكثر. إذا ما أعرف مرت عليكم بالcirculation، بدأوا الآن كثير من ال pharmaceuticals they start using different animals immunoglobulins, precisely the goats. They're moving away from the mouse, which is probably the very common one, and the rabbits into goats nowadays. And هذا حقيقة أصبح له تأثير إيجابي كثير، بحيث هذه الحالات بدأت تقل بشكل ملحوظ جدا. You may easily طبعا it's more common in agriculture، المزارعين و those who animal breeders إلى آخره. بدنا نشوف حالات كثيرة post vaccination. Those who are requiring monoclonal antibodies, IgG, and so forth, treatment. So these are risk factors to develop the heterophile antibodies, which basically what it does, it can usually, but not always. يعني عادة لكن مو دائما, it causes an increase in the signal. The antibodies or the heterophile antibodies can be against the TSH, T4, T3, the streptobidin solid phase, and the ruthenium label just as well. مثل ما قلت لحضراتكم, now we're using antibody source from different animals, so this whole concept is getting less and less nowadays. This is a conceptual slide that depicting how the heterophile antibodies works with the TSH, causing the TSH signal to increase. And once you have increase in the TSH signal, this is the heterophile antibodies instead of the TSH hormone, causing the complex to formation, and therefore signal produced. Higher signal equal higher concentration, and by doing so, it gives you false high TSH. This is a case of to represent this notion. A 38-year-old lady with a goiter and a TSH of 6.8 and T4 of 45, which is significant or modestly elevated on the Immulite assay. The first thing we do, حتى يعني أوضح لكم إحنا how we approach it, is the first thing we do is to call the lab and tell them to recheck the TFTs on using a different assay or platform. And we usually go for Abbott, لأن Abbott مثل ما as mentioned, it's less likely to cause the antibody interference. So we did check it on the Abbott assay, and it showed that TSH was actually appropriately suppressed from 6.8 all the way to undetectable, while the free T3 was still high. So that was enough for me to call it heterophile antibodies affecting the TSH. Well, I can, for work completion and for academic purposes, I proceeded with dilution technique. And what we do with the dilution technique, so what we have here is actually high and high. In the dilution technique, it's a simple technique. When they decide to dilute the blood sample in 1 in 2, 1 in 5, 1 in 10, and sometimes 1 in 20. So when you diluted 1 in 2, you would expect the TSH to normally to drop down to from 6.8 to 3.4. And in this case, it dropped down to 1.2. So there was a significant non-linear relationship between the dilution factor and the baseline TSH. كل ما يكون هناك فرق كبير ما بين ال expected TSH وال measured TSH, معناها إنه this is an indication of antibody interference or interference عموما, right? On 1 in 5, you would expect the TSH to be 1.4 from 6.8, and it actually came down to 0.03. So again, this confirmed that what we're dealing with is an interference factor. الأبت قرأ مضبوط, الديليوشن factor طلع عندنا هناك interference. Well, finally, we use the antibodies and the repeat TSH after blocking. What the antibodies does is actually antibody against the interference antibodies. So it just blocks it and takes it out from the analyzer. And the TSH with the antibodies tube was again suppressed. So the diagnosis was confirmed without any hesitation. This is a heterophile antibody interference with the TSH. So this by going through this process, we were able to A, establish there was interference, and B, we were able to establish that the interference was specifically with the TSH, not with the T4 or the T3. Now back to the dilution technique, it need to have أول شيء يعني هذا شغل الباثولوجي scientist مو شغل endocrinologist, but we need to know لأنه discussion حيكون one-on-one with them, and I'll show you an email that I've got yesterday from one of them to this factor. لأنه الساينتست ما يشوف المريض, they only deal with numbers. We see the patient. So at the end of the day, we have to make the final call, not the scientist. With the dilution, you need to have a significant deviation from linearity. That's what it counts. مو subtle changes. وعندي case we had dilution مو كلش accurate, لكن حقيقة مثل ما هاي الحالة dilution لازم يكون deviation from linearity, it has to be quite significant before you sign on it and you call it a positive test. Another case of 48-year-old patient who had total thyroidectomy for thyroid cancer, and he was deemed for suppressive thyroxine doses. لكن كل ما نزيد الدوز ال TSH كان always hovering at يعني 0.2 milli-unit per liter, but never been suppressed. يعني حقيقة إذا تلاحظ هنا بزيادة الثايروكسين دوز, هذا الكلام كان في 2010. صعدنا T4 من 18, 19, 20 إلى حد 26, but TSH hasn't dropped down. Now, بالسيمنز analyzer. Now, if إذا كان الفيزيشن يعني نظرته عامة للفحص, you can easily miss out on the diagnosis. Now, a T4 of one change مثل ما بينا بأحد السلايدات السابقة ممكن يؤدي إلى tripling the or doubling at least of the TSH value. هذا صعد عنده من 18 ل 26 والتي اس اتش بعد يقرا 0.2. So this is quite aberrant. This is abnormal. Should not be looked at as a normal thing. And of course you need to know which analyzer. التغيير ما بين اكو عندهم المختبرات المفروض عندهم their own coefficient of variation. بعض المعادلات يطبقوها حتى يقارب ما بين الفحوصات اللي يسووها بأكثر من مختبر، لكن احنا نفضل ان الفحص يكون في نفس الانالايزر عموما. فthe next step مثل ما بينت بالحالات السابقة انه نروح على الأبت. في هذه الحالة الأبت قرأ نفس الشيء 0.22, still not suppressed, right? We did a scanty bodies tube study that showed the TSH was actually suppressed. Now, this is a case of heterophile antibodies against often. So this is a case of heterophile antibodies. لكن أنا حقيقة خليت هذا الكيس لأكثر من سبب. أولها يعني أبين كيف لازم نهتم إحنا بالتي 4 وال any subtle changes خاصة بهاي الحالات الصعبة. Now النقطة الثانية اللي حبيت أبينها بهاي الحالة إنه الأبت architect وإن كان لأنه بواشات period هو شوية less likely to be affected by heterophile antibodies, لكنه still يعني ممكن يصير به heterophile antibodies. That's another case to demonstrate that the Abbott architect is not perfect, nevertheless. Now, moving along to the third case of وأنا عندي حوالي 8 حالات ما أعرف 9 اليوم. 45-year-old female with a TSH of 9.5 and T4 of 65, so high and high, right? Now we did the dilution, and I hope you appreciate that the expected dilution 1 and 2 and 1 and 5, 4.7 against 4.5, 1.9 against 2.1. فأكو يعني non-significant loss of linearity. احنا نريد الفرق بين دول يكون ملحوظ، مو 0.2 or 0.2 أيضا هنا. This is, I actually put this case to demonstrate what's not significant when you do the dilution test. ويرجع لك الباثولوجيست ويقول لك والله اكو non-linearity، اكو فد discordance ما بين ال expected وال measured result. We tell them no, we need 1 or 2 point difference, more decimal point difference. Again, the heterophile antibodies were not detected. We did retest the on the Abbott as we usually do, and it showed that the T4 has dropped down to 9, while the TSH was still reading 9.2. So this is a case of autoantibodies to T4. الحقيقة this is not uncommon at all. Autoantibodies هاي مو heterophile antibodies, right? أكو فرق بينهم. The point that I'm trying to make here, that when you have high and high, you don't know which one is causing what. Is it the heterophile? Either can interference. Is it affecting the TSH, or is it affecting the T4 or the T3? فمن يكون عندك ال dilution study is normal, then the TSH has been cleared. It's not the culprit. مو هو المسؤول عن المشكلة. الهيتروفايل antibodies بالسكانتي تيوبس حقيقة it looks for a limited number of antibodies. It doesn't cover all the interferences, right? So, and I will mention that in a specific slide as well. على كل حال, we knew from this test that the T4 was falsely elevated in the Immuolite. 65 was a false high readings. It was actually 9 on the Abbott architect. So the autoantibodies against the T4 and T3 is not particularly rare. It's up to 1% of the population, who, particularly those who have antithyroid antibodies, almost 100%. 8 out of 10 to 10 out of 10 patients with these kind of problems, they tend to have TPO or thyroglobulin antibody positive in this Japanese study. So it's almost 1% of the population could have this problem. They can have antibody to anti-T3 or anti-T4, لكن مو كلهم. Right. Moving along from there, and I think this is important. This is another case that I saw 2 months ago. يعني حتى لا تصورون إنه هذا rare. This is a case of 17-year-old with gynecomastia and delayed puberty. And it could tell that his testosterone is still low, LH is undetectably low. So he hasn't really started puberty. And the gynecomastia turned out to be adipomastia. The prolactin was normal, the TSH of 3.4 upper normal, the T3 was 6.1 elevated, T4 was normal. أنا يعني آسف إنه المحاضرة هذه كلها أرقام و T3 و TSH, but يعني this is the best I could simplify. يعني ما أحاول أخليها ما تكون stereotypical ولا يعني مملة. لكن واقع الحال هي this is a true endocrinology. This is all about numbers. Now, moving along, I did repeat اللي احنا نسوي دائما. We have to repeat the test to make sure that we're getting the same number. And بالمرة الثانية هذه في أكتوبر، هذه في 4/10 هذه السنة. TSH count 5.1. T4 again was normal. T3 was again elevated. Now, I've told the patient and his mother who was with him that he is going to get to puberty, just a bit of delay. There's nothing to really worry about. And we did MRI to make sure it's not central and so forth and so on. It's all came back normal. لكن اللي أحب أقوله إنه من I've sent the sample to a different analyte, and that was in the Beckham analyzer. And you could see here in the that was in Monash Hospital, the T4 on a different analyzer, where it read, it was a Siemens actually, بالمرة الثانية, it dropped down to 5, so that was quite normal. Now we could read here, this suggests, this is the scientist from the pathology, and he sent me this interpretation himself or herself of the result. This suggests that this patient has interfering antibody that affect the free T3 assay, right? So, and again, this child or this young man did have TPO antibody, TG antibody positive. So that's another case of showing when you get high and high and you still can. بهذه الحالة أنا ما سويت أي dilution ولا أي شيء على الإطلاق. I just went to a different analyzer and gave me the answer, and I was happy with it. The heterophile blocking tubes, I thought I put the slides here. لأنه الحقيقة من يجيك من الباثولوجي يقول لك والله خلينا سكانتي تيوبز وما أعرف إيش أو سكانتي بوري تيوب وطلع نيجاتيف التست ولا طلع بوزيتيف. You need to ask the pathologist. Well, I do ask the scientists, how significant was the result? A significant change in the numbers, that's indicate interference. More minor changes, okay? Now, if the antibodies test came back showing no change in the TSH and the T4, this does not mean in any shape or form there is no interference. ما يلغي الانترفيرنس، اوكي؟ لان السكانتيبريز حقيقه مخصصه بالدرجه الاساس للمايس والرابت derived antibodies، right؟ فخلي هذه اذا احنا فاهمينها هذه بشكل واضح يعني حقيقه تكون اسهل علينا. اذا يجي الفحص طبيعي ما تغير، ما يعني انه ماكو interference. Right? لكن إذا إجا showing significant delta ما بين TSH pre and post tubes, now that's indicative of interference. Now, again, identifying the interference, so the stepwise approach اللي إحنا حقيقة we should standardize it in our practice is the first thing we do is we talk to the lab. وأنا عندي email. I got it yesterday. I will try to share it with you as well. Talk to the lab, repeat the assay on a different platform. Usually we prefer the architect لأنه هذا be 2 steps washout فبالتالي أفضل. Repeat the TSH in dilution. هذا الدايلوشن يخص الدايلوشن ما نسوي له T4 T3 مثل ما تعرفون حضراتكم، وإنما نسوي بس ل TSH, right? And of course, we can use the heterophile antibodies. Now, as long as you know, طالما تعرف حضرتك أو حضرتك إنه كيف to interpret the result. A minor result is not entirely positive. A negative result does not rule out interference in any shape or form. أكو حد عنده سؤال قبل لا أنتقل من حضراتكم قبل لا أنتقل للمرحلة الأخرى؟
أي أحد عنده سؤال؟
أنا مو سريع.
العفو، عندي سؤال.
نعم تفضل.
تفضل دكتور.
أشيدك يعني محاضرة رائعة وقيمة يعني على مود قلل أخطائنا بالعلاج المرضى. I'm neurologist. We are frequently asked for thyroid function because of hypo and hyper have many neurological manifestation. But this sophisticated investigation, I do not know whether our colleague from medicine is available in Iraq. We can do this checking and these different ways of analysis. Just we look at the reference value that differ according to the lab, but we do not know really the technique they do it in Iraq. Whether this Abbott technique is present in Iraq, we can double check the sample when we have a doubt. I usually personally, when I have a doubt, I refer to our colleague in endocrinology, Dr. Taha Mahi in Suleimaniya, and leave the battle for them.
Yeah, right.
Now
So-
we have only Roche platform, بس اكو بعض المناطق جابوا سيمنز واكو ابوت، فلازم you have to ask for the platform او تنتظر على طه محوي هو يقرر لك which platform, which normal values. We usually in Iraq we use the conventional unit rather than the SI unit. مثل ما استاذ غسان هسه قاعد يستخدم، فما نستخدم احنا الاس اي يونت، وكذلك بكردستان والاندر جراجويت ايضا ندرس على الاس اي يونت rather than مو الاس اي وانما الكونفنشنال يونت. فهاي مشكله، فافضل تعوفها على الاندوكراينولوجيست. طه ما هو يحل لك اياها.
Thank you very much. Thank you.
Yeah. Dr. Sawer, I have في محاضرات سابقة من
Okay, go ahead, Dr. Ghassan. Okay.
Yeah, we have established in the previous rounds that ممكن interference. We have established in previous round, Dr. Sawer, إنه the endocrinologist or physician need to choose two health professionals that we work with. We really have to be careful in when we choose them. And one of them is the radiologist who report to us, and the sonographers, for example, and the other one is the pathologist. So صحيح المريض يعني واقع الحال بالعراق حسب ما أنا أشوفه، يعني عموما أنا ما أشتغل هناك تعرف حضرتك، ولكن المريض يجي وجايب فحوصاته أو رايح لفلان مختبر وما أعرف إيش وكذا، فأتصور هذه خطأ يمكن يسبب مشاكل أكثر، وبالتالي يخلي نسوي فحوصات أكثر من اللازم. فاختيار المختبر مهم جدا في تقديري، وبالمناسبة هذا الشيء موجود هنا. يعني أنا ما عموما أحب أتعامل مع ملبن باثولوجي، في عندي أكثر من ساينتست أتعامل معاهم حتى هنا، لأنه I'm just, I know how they work and they know how I work, so it's a very strong work relationship and it's actually quite important. مثل ما بينت بالحالة اللي T3 طلع أنتيباريز، ما سويت أي فحوصات أخرى، تكلمت مع ساينتست وكنا مقتنعين اثنيننا وطمنا المريض don't worry about it، وهذه الأنتيباري راح تستمر معك، وخليناها بملف المريض، فهمنا المريض إنه أنت عندك مشكلة بالفحص، هاي المشكلة هي حقيقة يعني أنت مو سببها وإنما هي artifact، يعني شرحنا لهم إياها بطريقة بسيطة، لأن هذه الأنتيبوديز مثل ما تعرف ممكن تطول لعقود طويلة، سنين طويلة جدا مع المريض. alright. It's not straightforward. مو كل الحالات حتكون بسيطة وواضحة يعني للأسف. والله مو للأسف، احنا we like the challenge, otherwise endocrine would have been boring. So we're okay with that.
دكتور غسان اكو internal feeling we always trust one lab. I don't know whether private or governmental or hospital, public or private sector. We always trust one lab. We have to go to that lab and see which platform they are using. We have to have a good relation with the technicians, with the biologist who is working on the machines. وإلا ما تبقى إنه بس I will deal with numbers, you will have a lot of problems.
أستاذ غسان.
نعم.
العفو. دكتور مقداد سؤال يقول still we didn't talk about the macro TSH.
Yeah, I will later on. I will. There's a slide for it.
Okay. وملاحظه من دكتور علي، يعني هو يعني recommend don't dependent single reading, better to test.
Why to test?
Yeah.
Why to
يعني
test?
هاي recommended دكتور علي هو يعني مثل نوتس، يعني قصده استاذ يعني تو ريدنج قصده مو تو تيست، اعتقد
إيه.
هيك قصدك دكتور علي.
Hey, two determinations. Yeah, of course. That will show. That will show. You're not gonna go. يعني إذا يطلع عندك TSH عالي و T4 عالي لازم تروح تسوي لي MRI pituitary, right?
Sure.
So we need we definitely need more than one test. وأنا أتصور بالحالة السابقة بينتها. هنا 3 مرات سوينا الفحص لهذا المريض. T3 6.1 بعدين 7 بعدين 7.2 نهاية الشهر العاشر، وبعدين دزيناه على مختبر آخر. بالقراءة الثالثة يلا شخصنا الحالة بعد 3 قراءات مختلفة. Now, if I can move on to the next topic of tonight's presentation.
استاذ غسان العفو.
نعم.
استاذ عباس الموسوي ما شاركنا الرأي، واعتقد عنده مور اكسبرت في الشغلات. استاذ عباس تسمعنا؟
اي السلام عليكم، شلون صحة؟
عليكم السلام.
تسمعوني؟ دكتور غسان مشتاقين، شلون صحة؟
شلون؟
الحمد لله على السلامة.
انا اريد اتحارش فيك استاذ، اريد اتحارش
اي
فيك.
لا انا دا اسمع على كيف، لان هاي احنا مشكلة نواجهها الحقيقة، نواجهها يومية يعني. وتدري هذا يعني in availability of the other tests خلينا يعني الحقيقة يعني challenge فعلا. يعني انا ذاك اليوم مثلا شفت في female patient on very high dose of thyroxine TSH very high، وبعدين يعني شفت هذا التايروسين the new one liquid، اذا سمعان بي يعني اكيد مستعمل او مر عليك، لان the other tests are not available يعني هي ما اعرف I don't know where we are. فذني والسيريال ديليوشن بالعراق عندنا شويه كيمست مو هالقد يتعاملون وياه، من تكتب له يجوز يسوي لك اياه بس ما نعرف الميثودولوجي قد اكيوريت مالتهم. I don't know really بالنسبه للسيريال ديليوشن. وهاي الانتيبوديز against the heterophile antibodies are not available definitely probably academic يعني على مستوى academic مو على المستوى الببليك يعني. اي academic اعتقد يعني if they are available.
والله استاذ هو اذا اكو راش استاذ علي عباس من البصره عفوا، اذا اكو راش هذه عفوا اذا اكو ابت ويا الروش هذه يحل لك مشكله كبيره فيما يخص
احنا عندنا سيمنز وروش.
ماكو
السيمنز حقيقه إيه ما عندنا حتى مو اميولايت. السيمنز مالنا مو اميولايت غير انذر جنريشن. تعرف انتم عندكم باستراليا اميولايت، شفتك عارض اميولايت
طبعا.
احنا ما عندنا اميولايت ولا اجى يعني ما
استاذ هو ابت ما موجود بالعراق؟
لا يعني الشركه ما قاعد تدعمه.
لا كان موجود، كان ابت موجود سابقا، كان موجود بس
وفي
كل
كل
مستشفى الحاضر ما
موجود في كل مستشفى اكو ماشينز بس ما تشتغل. فهو عندنا يعني تقريبا هسه الماشي روش ترى هم بها مشاكل. عندنا مشكله بالعراق وبالعالم. روش اكو مشكله مثل ما قلت far away from perfect. فعندنا مشكله بالبلاتيفورم يعني نضطر نغير بين بلاتيفورم واذرز، بس شيء اكيد احنا we are far away from the perfect thyroid assays. دكتور احنا قاعد نسوي بالعراق we wait and see, we don't rush, we always don't diagnose the resistance thyroid hormones الا we take 5-10 years before we diagnose. We take the family also screen. وهذا الهيتروفيل antibodies by repeat the platform يعني من السيمنز تحول على الروش وبالعكس. وما عندنا غير 2 بلاتيفورمز، اكو بعض المحافظات اذر بلاتيفورمز بس المشكله ما قاعد يكتبون مثل ما
دكتور محمود التميمي يقول ابوت افيلابل انفيقار.
اي بس يشتغل يعني يشتغل ثايرويد.
عفوا استاذ في ولا in the private sector we have يعني ابوت وروش.
هذا يحل لك مشكله هواي دكتور قصي. هذه يحل الابوت يحل لكم مشكله مو دائما لكن يعني ممكن يحل لك مشكله كبيره في كثير من الحالات. الابوت لين بيوشع فايز كلش لطيف.
انا ايد كلام دكتور قصي بالبرايفت سيكتور انا هم شايف ابوت استاذ، بس هو
بس
يعني
اتمنى نوصل جماعه المختبرات طريقة أنه يكتبون البلاتيفورم بنهاية التحليل، قليل يكتبون روش والبقية ما يكتبون شنو البلاتيفورم. ولهذا الأخ من كردستان من يتكلم كان يتكلم he don't know which platform they are using. هو صح مو interested بالفيلد، بس لازم كل واحد يعرف which بلاتفورم. أنا ما معقول أقارن بين ال TSH بالأبوت مقارنة بالروش أو بالأذر إميولايت لازم كل واحد يعرف النورمال فاليوز مالته مال الكيت، مو بس النورمال فاليوز which platform are you using.
دكتور محمود من فيقار يقول يعمل يعني فيروت فانكشن تيست اند اوتو انتي بودي.
نعم هذا طبعا غير نورمال فاليوز، طبعا راح يترتب عليه غير نورمال فاليوز بالمناسبه كومبليتلي ديفرنت.
اكيد
معناها اي تقرير تحليل يطلع لي من فيقار بعد ما اعتمد عليه من داتا النورمال فاليوز مالته تفرق عن اللي عندي.
هذا الكاليبريشن هذا قلنا بأستاذ هو الكاليبريشن يختلف ما بين الاساي والثاني.
نعم ولهذا هاي مشكله
استاذ. يعني انا اقصد انه في المستشفيات الحكوميه واصبح
لا ما عندنا مستشفيات حكوميه، ما عندنا بس روش ومو كلش متوفره في كل مكان. اكو مشكله بالهرمون فيري اكسبنسيف.
اوكي
اكو هسه دخلوا السيمنز دخلوه بالكرخ وبالرصافه بس بمشكله السيمنز، ترى الثايرويد سيمنز بيه مشاكل كلش عويصه. واحنا ما عندنا اميولايت باي ذا واي، ما عندنا اميولايت، عندنا انذر ماشينز بس هي نيو سيمنز غير الاميولايت 2000 اللي كانت معترف بها عالميا. انتم عندكم اميولايت 2000 دكتور باستراليا؟
يعني الاميولايت الحقيقه عندنا احنا not very popular. مو كلش مرغوب.
انا شفتك عرض الداتا من الاميولايت، شفتك عرض الداتا
كان هذا نعم. هاي الحاله كانت 2010 استاذ، كانت قديمه.
استاذ استاذ غسان دكتور بريسك عنده تعليق. تفضل الدكتور بريسك من اربيل.
تفضل.
مرحبا دكتور، شلونك؟ ان شاء الله زينين.
هلا دكتور.
انا اسف انا شوي متشن دا اسمع المحاضره يعني كلش زين، لان صراحه كنت اسوق ودا اسمعكم يعني كلش انترستد. عاشت ايدك يعني. بس عندي بس يعني توضيح بسيط اذا على الهيتروفيل انتي، بس الفكره يعني اذا كمختصر يعني هي اذا الواحد مثلا راح يجي هو المريض هو هايبوثايروديزم، مو صحيح؟ انا هيك اللي وصلت لي الفكره انه هو هايبوثايروديزم واحنا نعطيه تريتمنت ويظل تي اس اتش ريزيستنتلي هاي. هيك الفكره لو انا غلط نفتهم الفكره؟
لا مو هيك الفكره. هو
لا
موضوع
wait until I get to that. خلي انتظر لما اصل هاي الفكره مالتك.
تمام انا هسه وصلت بكذا اسمع اكثر.
اوكي
شكرا
لا welcome. يعني just drive carefully now, drive safely. But
okay استاذ غسان.
all right, so yeah, we'll move on to the all right. We'll cover all these salient areas as I go along. Now back to this boring topic. أصبح إلى حد ما ممل. هو البايوتين interference والhealth products. الكمية اللي تستخدم بالhealth products حقيقة هي negligible. all right. ولكن ممكن تأثر. واللي أحب السبب إنه أنا خليتها بمحاضرة مو يعني حتى أوضح أكو update صاير بها. The new Roche analyzers and assays are actually more biotin resistant. They're not biotin proof مثل الأبوت اللي يستخدمون paramagnetic antibodies. لكن they do use fortified antibodies تقاوم البايوتين. بعبارة أخرى you really need to have a high dose of biotin consumption to affect your thyroid function on the Roche, on the popular Roche assay. أنا حركز على الروش لأن المظاهر هو اللي موجود بالعراق. Okay. Now, how does the biotin affect the assays? It reduces the signal of all the hormones, TSH, T4, T3. Now احنا قلنا إذا لأنه أكو biotin هنا، فإذا عندك too much biotin in the blood sample, it will occupy more of the solid streptavidin باختصار يعني وببساطة. وبالتالي it will reduce the signal. Now we agreed in the TSH sandwich assay when there is a drop in the signal often when there's a drop in the signal, it will read as low concentration. العلاقة طردية, linear, right? High signal, high concentration. Low signal, low concentration, right? So TSH يقوم يقرأ عندك قليل. العكس تماما فيما يخص T4, T3. Again, we'll drop the signal. لكن من drop the signal بالcompetitive assay معناها الهرمون عندك يقوم يقرأ false high. For overall picture will look like a hyperthyroidism بالbiotin contaminated assay blood samples. Now this is what it looks like, just to show you how it dropped the signal in the competitive assay. So these purple triangle represent excess biotin and will occupy the streptavidin solid phase, and therefore there won't be any signal. Mako A antibody antigen complex will drop down here, and therefore the signal will be lost. Low signal equals higher concentration. Okay, for overall picture will look like hyperthyroidism, right? So this is a case of 55-year-old male with multiple sclerosis. He was prescribed 300 milligram a day of biotin. We knew from day one this is interference. من يجي عندنا T4 يقرأ more than 100 with TSH not suppressed. الهايبرثايرودزم مو يعني الارقام مو مثل الهايبرثايرودزم الطبيعيه اللي نشوفها بالحالات، هم شويه مخربطه في حاله، لكن عموما حيكون عندك T4 عالي و unsuppressed TSH. This is how I put it, okay? فمره في قراءه اخرى من وقفنا البايوتين، واحنا ننصح بان يكون البايوتين جرعه عاليه لازم توقفه 3 ايام مو يوم واحد. اذا health products one day is enough to stop. نقول للمريض، واذا ما تسال ما راح تعرف. اذا ما تقول للمريض انت تاخذ health products beauty products خاصه للفيميل وما اعرف ايش، لان هم ياخذون البايوتين حتى يمنع تساقط الشعر، ما ينزلون وزنهم. احنا نعرف وسبب تساقط الشعر عند النساء بالدرجه الاولى هو الweight gain which increases the testosterone level. Now, moving from there, so off biotin, everything came back to normal, and we told that patient, don't worry about it. This was a false alarm. We don't need to do anything else. Okay? فمو بالضرورة كل مريض يجي تودي على الداليوشن وعلى الأبت وعلى ما أعرف إيش والهيتروفايل antibodies, كانتيبوديز وما إلى ذلك. Now, I need to move on to another case that I saw, I think it was in May this year. No, actually, it was in September. An 80-year-old lady who has been treated with immune check inhibitors for metastatic small cell lung cancer. She was already known to have iatrogenic hypothyroidism. She had her thyroid taken out for a big thyroid cyst and multinodular goiter 15 years ago. Historically, she was requiring 75 microgram thyroxine. All of a sudden, they have to drop it down. That was the thyroxine. That was the TFT levels when I saw her in September with the T4 with the free thyroxine. بالمناسبة احنا بإسرائيل مثل ما تعرفون حضراتكم بس نستخدم الفري T4 وهذا نسيت أذكرها بالبداية يعني why we prefer free thyroid hormone over the total. Anyway, the free thyroxine was 27. The TSH was not suppressed. فهذا احنا نسميه high and high, all right? مو بالضرورة يكون elevated TSH, but it really should be suppressed here. So when I saw the patient, she told me that the thyroxine was dropped down from her historical dose of 75, which was doing okay with it for 15 years, and that has to be stopped all of a sudden to 50. Now, moving from there, she told me that, you know, she's quite adherent to thyroxine. She takes it first thing in the morning appropriately, alone with no other medication whatsoever. She did take vitamin D and calcium, وتعرفون هذه ممكن interfere with the thyroxine absorption. ولكن هي تأخذ الحقيقة after dinner. So there's no interference between the tablets. Now, looking at her thyroid hormone profile, in June, somebody looked at her GP الحقيقة, look at her T4 was going up until hit the 32, and it started to drop down the dose when the T4 was 32. And that's when I saw her here was 27. At any time that the TSH was not suppressed, okay? So what did we do? I called the scientist حقيقة the pathology registrar بعده هو متدرب وقلت له عندي هذه المشكلة. There's something funny going on with this lady. More likely we're dealing with interference. Okay, it's all right. So he got a blood sample. On the Beckman assay, the T4 read 27, T3, both high. On the Roche assay, they were high normal, but they were normal. On the Disorian, it was high again. Now, the catch here, Roche was fortified, so it shouldn't really be affected by biotin that much anymore. Not anymore. The Disorian, they use paramagnetic TSH-T43. It really should read accurate. It really should give you accurate result. Well, the Beckman had a paramagnetic TSH, but the T43 were biotin based. Okay. Now, what he did, and he was very, حقيقة comprehensive and enthused with his work, and he did a great job. What he did, he did a biotin depletion kit, and for the Beckman sample, the moment he used the biotin depletion kit, it took off the biotin off the blood sample. The T4 dropped down from 27 back down to normal. لكن لاحظ بالروش it did not change ما بين البايوتين depleted روش والستاندرد روش. فأنا حقيقة سألته قلت له ليش ما تغير؟ قال لي because it's biotin resistant. This is a Gen 1 true reading. Okay, if that's the case, how come the Disorian, which is paramagnetic and it should be biotin proof, لكن قرأ عالي؟ I called the patient and I told her what time you took the thyroxine tablet that day of the blood test, and she took it an hour before, 2 hours before she gave a blood sample. So this explains why the T4 here in the biotin resistant or proof were on the high side. Okay. هاي التفاصيل مهمة. طبعا رحنا حكينا ويا المريضة وما أعرف شنو، بعدين قالت والله أنا أتذكر صحيح أنا أخذ health products for my hair and nails and it has biotin in it. So it did cause this issue with the Beckman. Beckman is actually not حقيقة من مثل الإميولايت قديم، لكن بي بعض إيجابيات، لكن عموما we use it as a من نريد نستخدم أكثر من one platform. We call for the Beckman. Now, moving from there, this is what I need to show everyone, okay? The biotin interference, it should not affect the Disorian or the Abbott because they are paramagnetic. Zero effect on any of these hormones. ما حد بيهم يتأثر. Right? Full stop. البقية يتأثرون. سيمنز، الروش عليه استركسينا لأنه أصبح، والسيمنز كذلك لأنه أصبحوا they're using fortified biotin analyte وبالتالي they are resistant. فبالsmall biotin doses اللي موجودة بالhealth products, it really shouldn't affect the new generation of the Roche and Siemens. So that's a good thing. Yeah? هذا شيء جيد. Right? The Beckman هذا كارثة. Right. Now, I'll move from this case to the case when you have high T4 and unsuppressed, and a high TSH. So what we see with these cases is usually there's analytical interference, TSHoma, the thyroid resistance. We know how the differential move. TSHoma, thyroid hormone resistance, analytical interference should go up the list. لأن البقية uncommon, acute psychiatric illness, macro TSH, and thyroxine treatment. And I think thyroxine treatment is probably the commonest amongst all of them. ولو في ملاحظة أيضا إنه the new generation assays they are ما يتأثرون بيا ساعة المريض تأخذ العلاج. مو كل الأسئلة لكن بعض منهم. هاي النقطة الآن كلش common cause for high TSH or unsuppressed TSH and high T4 لانه المريض اخذ العلاج، اخذ الحبوب قبل فتره بسيطه، ما اعرف شنو، قبل يسوي الفحص بساعتين 3. فاحنا نقول للمريض اخذ الفحص، اخذ الحبوب، اذا تاخذ الحبوب الصبح لازم يسوي الفحص الظهر، واذا تقدر تاجل الحبوب الى ان تعطي البلاد سامبل. Now, an example of which a 32-year-old lady who with with an elevated T4 and T3 and unsuppressed TSH, so that's high and high. It was picked up on routine examination, and the registrar suggested that she could have thyroid hormone resistance or TSHoma. We did the interference protocol, might-be dilution, might-be checked with the antibodies tube, might-be checked with the different assays. They all came back normal. So we realized this is not an interference. So this has to be something more interesting. The alpha subunit was 1 elevated, right? The next step would be to do a thyrotropin releasing hormone. We did that for academic purposes, and there was no response to TRH stimulation test, okay? The MRI showed 8 millimeter microadenoma, which is unusual to be an incidentuloma at this age group. Her whole pituitary panel came back normal, except the elevated alpha subunits. Again, the TRH releasing hormone stimulation test was negative. They showed no response in the TSH. So she underwent surgery and turned out to be TSHomas. Now, a quick run through of TSHoma differentiation with the resistant hormone. They're both unusual cases. So these are where you look at positive alpha subunits, family history, clinical status, and a positive MRI, particularly in the young population. I thought I'll put this slide from a recent study that showed the response of a group of patients to TRH stimulation. Those with TSHoma here, they show no response to any thyroid-releasing hormone stimulation test, while the control did show some response, and the thyroid hormone-resistant group showed even more robust response in the TSH to the TRH stim test, okay? I'll move on to another case of 16-year-old female who came in with undetected, with non-suppressed TSH and raised T4 and T3. There was no analytical interference, نفس البروسيس مرينا به, and she was clinically a thyroid. MRI pituitary was normal, she was only 16, and we did the TRH stimulation test, and it showed a significant, robust response to the TRH test. From there, we moved to genetic sequencing and proven to have a pathogenic variation in the one of the alleles, and basically we confirmed the diagnosis of thyroid hormone resistance type beta mutation. I'll move on from that case to another of a 64-year-old patient who had a recent facial surgery for orbital cancer, and he was on high dose of steroid. He was an inpatient with delirium and he had some seizures, and we thought we were not sure if the delirium was related to the pneumonia he contracted post-op, or was it related to the high-dose steroid? Now, you could appreciate, I hope, that the T4 was 44, significantly elevated, but the T3 was normal. Prior to that admission, his T4 was 13. And the subsequent test, مثل ما تفضل الدكتور قال احنا لازم ناخذ أكثر من فحص, they were all showing isolated T4 thyroxinemia. And in January, his T4 normalized by itself. Now, again, we did all the interferences protocol. They all came back normal. There's a genuine isolated T4 hyperthyroidism with non-suppressed TSH. The problem is, in this case, is basically it's actually psychosis related increased T4. So that's one of the cases that it's about 20% in one of studies in the psychiatric words. So almost 2 out of 10 who present with acute psychosis, they will have elevated T4, free T4 levels because of the protein carriers that can affect this condition. Pardon. Sorry about that. أحد عفوا.
دكتور مقداد كاتب بالكومنت does the patient on heparin?
No, he wasn't, but we think it's, no, he wasn't on heparin. But well, the mechanisms all got to do with the transferrin levels dropping down during acute psychosis. So this is well established. And once the acute psychosis is resolved, بعد ما وقفنا the steroid, everything came back to normal. Now, the impact of thyroxine treatment على TFTs هذا خليت 3 سلايدات لأن أتصور هاي حقيقة شيء لازم يعني we really have to be on top of. When usually patient on thyroxine therapy, they tend to run with a higher T4 level than their than the normal individual, or even if they are historically. So تاخذ المريض قبل تسوي له تايرودكتومي تقيس التي 4 مالته يقرا 16 واحنا قلنا 1 point variation، لكن من تاخذ he'll become athyrotic and you have to replace the thyroxine. You're going to go up to much higher level to achieve same level of normality. So that's something we have to bear in mind, and that does impact the TFT's analysis. Now, this is a study that I pulled out, not very new, and they have a group of patients. They divided them into 2 groups. Those who required, they both had thyroidectomy. Group 2 has thyroidectomy for thyroid cancer. Group 1 has thyroidectomy for Graves or multinodular goiter. And when you look at here, that the post-op thyroid level, T4 level, has to be much higher than the pre-op level to keep the same level of TSH while the T3 was not affected. So this emphasizes that once you start treating with thyroxine, you need to aim at a much higher level, okay? Now, this is my last case in this particular scenario, just حتى أخليها simple, يعني day-to-day cases.
من يشتغل بالطريقة سكرين؟
إذا ممكن الصوت. Yeah. So this is a lady whom I looked after for a while, and for about two years, and she's on thyroxine replacement, and she was well replaced until she came to me in August this year with a T4 of 24 and TSH of 2.8. So I went through the usual questionnaire. She's very adherent to her thyroxine. She takes it appropriately. تاخذ بالوقت المناسب إلى آخره. ما قاعد تاخذ أي PPIs ولا أي health products. So I've asked her what time you took the thyroxine when you did the blood test. She told me just before the blood test, about 2 hours. Well, I thought, well, it's about time that you need to take it, do it at another day, and don't take the thyroid tablet that the day you give the blood sample. So on that day, and that was a month later, when she withheld the thyroxine, the TSH, the T4 was dropped down to 19. So this is just a very simple, silly case of showing how simple things can make a lot of difference in our management. بتحل لنا مشاكل بدل ما نروح بفحوصات لها أول ما لها آخر. Right? Moving along to macro TSH, كان بعض أحد الزملاء سأل عنه. Macro TSH is not very common, but it's not rare. Macro TSH is exactly the same as macroprolactin. Okay, when you have some antibodies compounded with the TSH, and that will be less or biologically inert or less biologically active, لأن المولكول تكون too big to dissolute through the capillary walls. مثل macroprolactin ما راح يطلع من البلد، يبقى circulating بالبلد ما يوصل للtissues. Now, there is no family history, but I can tell you a few tips about it. It tends to, unlike the heterophile antibodies, the level tend to fluctuate quite a bit on the high side, usually. Okay. بالماكرو تي اس اتش يبقى سنه كامله ما يتغير، بالسنه الثانيه يصعد شويه يبقى بعد ما يتغير، بالسنه الرابعه يصعد شويه يبقى بعد ما يتغير، right؟ فعموما يبقى في تصاعد، لكن تصاعد بسيط، so a staggered process, right؟ مثل الدرج، but it doesn't fluctuate، يعني من يصعد بعد ما يرجع ينزل مره ثانيه، right? So this is how you think about it. Again, you will have high and high TSH and normal, high normal T4. So you'll have this, what I call it, unusual synchrony, between T4 TSH. Now, central hypothyroidism is when you have low and low, okay? In this cartoon here, نعم.
قبل لا نبدي اللو اند لو، اكو كم سؤال نطرحها على حضرتك.
Yeah.
اوكي. دكتور رافد يسأل يقول what is the effect of NAFLD and hepatic hemangioma raising TSH resistance؟ اكو علاقة
بين عفوا
النفلد والهيباتيك هيمانجيوما والتي اس اتش ريزيستنس؟
not that I'm aware of, actually. I know there was scattered report here and there, but we would never been flagged as an issue.
اوكي. دكتورة نور تقول thyrotoxicosis can manifested by psychological symptom. Should we deal with that high T4 بالكيس اللي قدمتها حضرتك؟
Now, T4 is now, this is an artifact. هذه مو قراءة حقيقية. سببها انه الكاريرز الترانستيريتين يقل فيطلع عندك high T4. Now, the T4 هو حقيقة less biologically active than the T3. T3 is the principal active hormone in the tissue, and as you could see in that case, it was always normal. So we decided not to treat. It's a good question. We don't treat.
Another question: if TSH normal with normal T4 and T3, but TPO increase, do you give any treatment؟ هذا موضوع منفصل، يعني قد يراد له محاضرة واحدة.
Normal يعني الكل اللي ترايو كله normal, but TPO increase. Do you give any treatment? No, we don't. You know, 10% of the population or more would have TPO antibodies. They are at higher risk of developing hypothyroidism, and you just have to wait for it to happen, if it's ever going to happen. So the risk of these cases to develop overt hypothyroidism is about 7% per annum. Well, some studies suggest 10, but usually less than 10% per annum. You just wait for it to happen.
Another question: what is the role of reverse T3 on reading thyroid function test? Thyroid.
Yeah, just particular thyroid in RCU patient, you might use it if you don't know the diagnosis. And we really, you know, the sick thyroid is very easy to diagnose. We have a good way of approaching it, and I'm going to mention that in the following slide, and well, the next few slides, if you can wait for it. So I have put a couple of slides for it anyway. Yeah.
Okay. Another question: central hypo could be normal TSH and low free T4 as well. Can I comment? أعتقد.
لا هو كان مو كومنت، هذا كان سؤال. قصده ممكن يكون عندك، إذا كان عندك normal T4 و TSH عفوا low T4 و TSH عندك normal، هل ممكن تكون هذه central hypothyroidism؟
لا كاتب central hypo could be normal TSH and low free T4 as well. Normal TSH.
question mark. خليه يسأل دكتور بريسك، خليه يسأل. شوف بريسك.
دكتور بريسك شنو سؤالك؟
هو يعني هو السؤال يعني احتمال مرات يكون التي اس اتش نورمال او نير نورمال، خلينا نقول باللو نورمال، يعني مو صحيح، يعني مو الا يكون التي اس اتش سبريست حتى نقول هذا السنترال هايبوثايرويدزم. هذا الشيء صحيح؟ لو اقصد يعني هو التي اس اتش ما راح يكون عالي
يعني
السنترال هايبوثايرويدزم، احتمال يطلع
قصدك دكتور بس unappropriate elevated.
بالضبط، يعني مثلا يطلع خلينا نقول التي اس اتش يطلع 1 أو 2 أو 1.5 والفري تي 4 persistent يكون لو on 2 to 3 measurements، يعني مثلا اكو separate measurements between
التفاصيل مهمة
2 months او شيء.
برسك التفاصيل مهمة. بعض التفاصيل الجواب على سؤالك موجودة أنا خالها بالسلايدات القادمة.
تمام
أنا آسف يعني التي اس اتش بالسنترال هايبوثايرويدزم will be very low. Okay, that's what I needed to get from. مو أنا شايف إحنا شايفين حالات التي 4 يكون 8 9 والتي اس اتش 1. Is this central hypothyroidism or not?
هي هذا السؤال. Is this central hypothyroidism or something else? اوكي شكرا دكتور.
I'll show you the case series.
شكرا دكتور.
السلام عليكم. العفو دكتور غسان، مساء الخير.
اهلا.
بس I have a comment on central hypothyroidism. I have come across a case for 2 weeks. Actually, the TSH, yes, not always low. It could be normal and sometimes mild elevated. And I have one patient who was treated with thyroxine as primary hypo for 2 to 3 years. And when I reviewed his lab before, I found the TSH never exceed 5 or 6. So I checked for the possibility of central, and finally I have got macroadenoma in the pituitary. So the TSH, and it had been written that the TSH in the central hypothyroidism may be variable. Yes, it is low, but it could be normal, and very rarely may be high. Thank you.
Yeah. So it's before our eyes, Doctor. هذا slide يقرأ. TSH may be in range, low or high, up to 10. T4 low or low normal, right? Reduced TSH bioactivity, and I'll take you through that. So this is, if you look here at this cartoon here, this slide here shows where the TSH could lie when you have central hypothyroidism and low T4. So what we usually I'm trying to take حقيقة ما تتكلم عن الموضوع بتفاصيله لأنه لكن what we usually ask the patient is إذا كان يعني isolated TSH drop very unusual to start with بداية يعني ما راح يكون عنده واحدة. Okay, very unusual. يعني إذا عندها في مريضة وعندها periods ولا المريض والكورتيزول طبيعي والجونادز مالته طبيعية, it's quite unusual. You still see it, but you really يعني you have to be unlucky to get that isolated. So that's one thing. What we what we do normally when we suspect these cases, we tend to avoid the Siemens and the Immulite analyzers because the calibration tend to give you false high TSH. Well, not false high, but they read higher readings. Okay. So I guess the challenge that Dr. Brusik said, what can you do when you have someone with a T4 of 8, for example, with TSH ما يتحرك 2. It's all in the history, doctor. اللي حاولت أبينه هنا, look at here the central cases of central hypothyroidism. This is these are case reports, and old case reports. TSH of 7, 8, T4 7, 8, 6. TSH كان إلى حد 6 هنا, but there was central hypothyroidism. They all known to have macroadenoma. Now, this is a different slide. This is what I wanted to tell everyone about. Usually, to start with the bioactivity مال TSH بالsecondary والtertiary hypothyroidism is الحقيقة هي كلش reduced. بالإضافة إنه TSH يكون قليل, مقارنة بالprimary hypothyroidism. These are the levels in this particular paper, and it shows the vast majority of patients with central hypothyroidism, they actually have the TSH under 0.6. So yes, you're right. You could get up to 10 TSH, right? وهذه الكيس عندك TSH of 6.1 here. ولكن mostly they are very low. Now, isolated TSH deficiency is uncommon. And if it happens, it usually TSH very low. لكن إذا عندك patient known to have macroadenoma where they have hypogonadism, this is where you usually get affected first. Hypogonadism, بعدين ال TSH, بعدين ال ACTH, بعدين إلى آخره. وحتى الجروث هرمون طبعا بالبداية. فإذا ما كانوا hypogonad وإذا كانت بالنسبة للمن والفيميل يعني أيضا still having her periods إلى آخره أو تقيس ال FSH LH in menopausal and is still high, very unlikely you're dealing with central hypothyroidism. Okay. Now ما خلت هذه الحالة لكن كان عندي حالة where I could look back on the patient profile and I see the TSH was 3 and 2 and 1 والT4 كان دائما 15 17 إلى آخره من هذه الأرقام. بعدين الT4 dropping to 9 and 8. I did pituitary imaging, came back positive for macroadenoma, but that was he was hypogonad as well. And ما أذكر ال IGF مالته كان قليل أو لا IGF-1. So this is my answer to you. Yes, in theory you can say مثل ما الدكتور محمود تفضل قال عندنا حالة وطلعت TSH, but was it in isolation? Very unusual, right? So that's in theory, yes, you could have low, normal, even high TSH with central hypothyroidism, but it doesn't happen in isolation. And when it does, it really have to have a very low TSH. Normally, I mean, usually it's a very low TSH. فهذا اللي يعني توضيح كان حقيقة جدا جيد. If I move on, إذا يصير عندي مجال أقدم بس على non thyroidal illness or sick thyroid, وأنا متأكد إن حضراتكم ناقشتوها over and over again. We still can identify which one, even in ICU setting, in acute illness setting, we still can identify which one is requiring treatment and which one is sick eothyroid or non-thyroidal. So this is our algorithm. If the TSH is above 20, this is hypothyroidism. If it's suppressed TSH, this is hyperthyroidism, even if the patient is in ICU. And they can have two diseases at the same time. Someone can have a car accident and head injury, and he is known to have hyperthyroidism. This is a case, from one hospital. They looked at the TSH for someone with non-thyroidal illness. And what you see here, the T3, which is the more reliable one, because it's an adaptive hormone, right? It's always low. The T4 can swing between low, normal. The TSH can be low or even high here, depends on the recovery phase. So your best marker is a low T3 and a TSH that's not suppressed and doesn't go beyond 20. You get your diagnosis. And of course, in the right clinical context. Now, back to the interferences, the كان سؤال من دكتور برزك إنه يعني يصير عنده لا الهرمونات تصعد. The answer is no. You can have the interference antibody, depends on the interference antibody. You can have higher low TSH, higher low T4, higher low T3. It depends, okay? Now, the macro TSH, I should have mentioned, حقيقة, it represents a case similar to subclinical hypothyroidism. مثل subclinical hypo. TSH is elevated, normal T3, normal T4. وعندي كيس حقدمها بعد شوي. البايوتين يشبه الهايبرثايروديزم مثل ما تفضلنا وناقشناها. الانتي ستريبتامين مثل الهايبرثايروديزم, very unusual, but there are case reports about it. الانتي ruthenium labeled antibody, it can go either way. right. اما thyroid hormone antibody مثل ما شفتوا حضراتكم بالكيشن اللي قدمتها التي 4 يكون عالي او التي 3 one of them but not both not both either T4 عالي او T3 عالي, right, بالthyroid hormone antibodies, and it's about 1% of the population. Now, so the practice response, before you start doing all sort of investigation, please ask the patient adherence. Are they taking the thyroxine first thing in the morning on empty stomach with water alone, no milk, and at least half an hour before breakfast? هذا الكلام اللي أعيده دائما للمرضى. First thing in the morning on empty stomach with water alone, at least half an hour before breakfast, full stop. كان هناك سؤال من أحد الزملاء إنه متى نستخدم متى الوقت المناسب إنه نعطيه thyroxine. Okay, there was a slide, I didn't put it in, but it showed that the evening, if you give the thyroxine late night, the absorption will be much more, the T4 will be higher than we like it to be, and it's fluctuate, it's not reliable. So I prefer morning one, right? And make sure that the patient doesn't take the thyroxine on the day he or she give the morning thyroid sample. If they did, they need to do the TSH in the afternoon. Now, خلي في بالك إنه إذا شيكت ال TFTs in the afternoon, the TSH will drop down by 1/3. Okay, يعني إذا كان ال TSH يقرأ 3 الصبح, الظهر يقرأ 2. Okay. وهذه مقدمية احنا في سلايدات أخرى في محاضرات آخرة. عفوا. If I can move on to, because I have 2 more important cases, and I will open the cases for discussions. This is a case of 75-year-old with low TSH and low FT4. If you look at the FT4, it's always been low all the way through. عدا هاي القراءة, البقية كلها قليل. السؤال دكتور رزق سؤال, هل هذه central hypothyroidism? Okay. What would you like me to do? MRI brain? She's 75. The chances for her to have a pituitary incidentuloma is about 10%, 1 in 10. So I'm trying to avoid doing MRI حتى لا أدخل في متاهة أخرى. Now, the antibody profile came back normal. She did not have any antibodies whatsoever. Her pituitary panel showed that the prolactin was high, normal, and cortisol, LH is elevated, and FSH, so that's appropriate. So her pituitary is functioning. So I start to think, okay, am I dealing with central hypothyroidism, isolated central hypothyroidism, where the TSH usually under 0.6, but her TSH was, 0.6, there was 0.1 here, and then was 1, and then 0.8, and there was 2. It doesn't look like central hypothyroidism. And look back in her profile in 2019, she did have a TFT that showed had a T3 of 6 elevated. So she did have isolated T3 hyperthyroidism. Now, if you look at the levels here, they always of the T3, they were high normal. They were not high, but they're high normal. In 2 readings prior to that, the T3 was 6 and 5.9, again, high normal. So I did thyroid ultrasound. It showed a lot of nodules and a patchy uptake on the nuclear scintigraphy testing. Quite a bit of patchy uptake consistent with toxic multinodular goiter. I did radioablate her. Post-radioablation, her T3 settled, TSH picked up, and T4 picked up as well. So the reason why she's having low T4 is because of the negative feedback loop from the high T3. So that's another case. Before you jump and say, okay, she's having central hypothyroidism in isolation with a TSH of 1 and 2, that's quite unusual. It turned out to be a local problem related to the thyroid gland itself. Moving along from there, I'll move on to my last case, which I've been seeing for the last 2 months, of an 18-year-old young boy who was referred to me with lethargy and low testosterone. The GP checked his testosterone was low. He previously healthy on no regular medication. He's a very sport and athlete boy, very masculine, examination-wise, unremarkable, clinically euthyroid. His testosterone was low, and I'll show you the result. There was no family history of endocrinopathies. He himself has no history of nephrolithiasis, but he did report polyuria and polydipsia. He did have some non-tender gynecomastia. He was very well androgenized. He was very masculine, visual field normal to confrontation. He had puberty at the age of 9, so he had a precocity, mild precocity, and he was normosmic, and he did report low libido. So that was his testosterone when I first saw him, 10 and 10.6. Lower normal was 12. The SHBG was on the low normal side. The LH luckily was detectable, and actually decent LH and decent FSH. The free testosterone was low in one reading and normal, just normal on the other reading, low normal, okay? I did dual osmolality, and because he's having polyuria, polydipsia, the urine was dilute in one reading, but then he told me that he stopped drinking water at night and he wakes up with a concentrated urine. So it worked. So apparently الظاهر كان يشرب هواية مي خاصة بالليل to keep himself hydrated, وبالتالي كان عنده diluted urine and polyuria, appropriate frequency, not polyuria, but appropriate frequency. His 1 milligram DEXA suppression was normal. We had normal cortisol. And I looked at it, and the testosterone started to pick up. Now, why am I talking to you about testosterone and this guy? Because his TSH was 5.8 and 7, was always high normal. His T4 was normal, and T3 was normal, right? So what do you like me to do? I called the pathology. I did check the antibodies was negative, thank God for that. And that's my pathology request form to the Michael, who's our scientist registrar in Melbourne pathology. And please check for macro TSH. Macro TSH يعني معناها interference. أي antibody interference ممكن يكون macro TSH. That's what I thought anyway. So Michael حقيقة هو اللي خلى هاي التيبل مشكورا يعني. So سوى heterophile antibody ما كان اكو اي change بالTSH, وبالتالي there's no heterophile antibodies limited to that scantibodies. He used the Roche and the Abbott assay, and there was no, and the Disorian, again, there was no differences between the TSH. So there's no evidence of interference. He did dilution of the TSH, and it diluted appropriately from 4 to 2, 1 and 2, 50%, 4 and 2, 1 and 1.4, 1 and 2.2, right? Now, he went ahead because of us specifically for macro TSH, and I called Michael, can this be a macro TSH? I don't know what I'm thinking of macro TSH, but nothing else seems to be, there's no interference. What we're dealing with here, and everything else is normal. And I'm not worried about the testosterone, just a sideway problem. And he did the PEG recovery, and it showed there is no precipitation. So we do, just like we do with the prolactin, we do PEG recovery, we're using the polyethylene glycol, and that didn't budge really much, didn't change much with the precipitant. Usually you like to get more than 75% precipitation to call it macro prolactin or macro TSH. So the case is open for discussion. Michael reported to me. So actually I might actually share with you what what it means to have a good work relationship with your pathologist. This is the email I've got from Michael. And it shows here that he sent me a nice article. I'm trying to show, we have reviewed this result with our senior pathology team. راح نناقشها مع التيم كله اللي عنده, right? ورجع يقول لي لا اكو interference ولا اكو macro TSH. طبعا انا سويت pituitary MRI لهذا المريض لانه low testosterone unexplained and came back normal. I've sent this slide this morning to Michael, and I told him, Michael, could that be it? The 5% of the confidence interval of the general population can skew outside the normal reference range بنسبة معينة. في فترة معينة كان هناك بعض يعني دعوات من بعض medical authorities to extend the TSH reference range to 6 حتى نخلص من هاي المأساة ونقلل subclinical hypothyroidism diagnosis because it could be overdiagnosed according to them. So my interpretation of this case, in this case حقيقة هذا عنده normally his TSH will be sitting always on the high normal range between 4 and 6. This represents 5% of the general population. We still see them. إذا أنت تشوف بالشهر 100 مريض thyroid, 5 of them will have to have a high TSH, and they not classified and should not be classified as subclinical hypothyroidism. هذا slide أنا عارضه في محاضرات سابقة, and it seems to be related to TSH receptor or TSH molecule polymorphism that's not necessarily related to age, season, weight, or subclinical autoimmune disease. And his antibody profile was negative anyway. This is my last slide. I'll stop here and I'll start taking your questions. Thank you all.
شكرا أستاذ غسان على هذه المحاضرة الرائعة. وهو من الزملاء عندهم أسئلة كثيرة عن المحاضرة. هنا السؤال اللي جاء what is the best way the time giving thyroxine جاوبته حضرتك. Can we given the total weekly dose as a single dose or 2 or 3 doses per week, or the dose must be equally divided? And thanks.
Yeah, well, the answer is yes, you can. But the problem with the with this approach is you will have a raised TSH for about 2 days of the week. And we don't know what's the pathogenic consequences of having a high TSH for the first 2 days of the week towards the end of that loading dose. So it has a trough, okay?
Yes.
We still use this approach to diagnose malabsorption, to differentiate between malabsorption from pseudo malabsorption. وأنا عندي محاضرة إن شاء الله حتكمل قريبا بهالخصوص هذا بالذات, لأنه هذا التست هو ناجع جدا وجيد جدا. We definitely do not recommend using this weekly approach in the older population or any person with ischemic heart disease. There are some very handful of cases when we really had to give this approach, give the weekly dose because of the poor adherence, and we can get one of the family member, أحد أفراد العائلة, يروح للمريض مرة بالأسبوع يعطيه العلاج أو يعطيه العلاج ويراح مرة واحدة بالأسبوع, right? فوافقنا
وهي هاي الحقيقة أستاذ غسان بالعراق عندنا الكومبلاينس مالتنا كلش تاير, فيعني هي هاي يمكن أكثر يوزز لهذا الموضوع.
نعم. Yeah. So what can you do?
Another question: It is reliable to measure free T4 in conventional method without equilibrium dialysis method?
Dialysis method, we don't usually refer to it unless we have, unless we cannot resolve the interference. And we don't, الحقيقة احنا باستراليا ما عندنا dialysis, وعندنا بس tandem mass, and we do use it if we're stuck with something. Now اللي بس حبيت اللي يريد أقوله إنه الفرق بين التوتال تي هرمون والفري هرمون. Why we prefer the free thyroid tests, because there's the confounding factor اللي هو thyroid globulin. There's factors affect the thyroid globulin level. وأنت قاعد تستخدم indirectly trying to measure the total hormone because it's such a small amount, picomole, and يعني قاعد تستخدم antibodies to catch and use subtract signal قاعد تطلع عندك ايش قد ممكن هاي indicate levels اللي عندك, ف it will augment the confounding factors. إذا كان هناك عوامل تؤثر على القراءة، هذه العوامل تتضاعف من تستخدم indirect method to assess the يعني assess the thyroid hormone. So the answer in a nutshell is these hormones, the immunoassay, are reasonably reliable way, and we do gauge our thyroxine dose according to the thyroid levels. ما عندنا مشكلة بهالموضوع. أنا اللي قدمته هي حالات استثنائية.
Okay, another question. Why we can't send for serial dilution when we suspect antibody interference with TSH, while we didn't recommend the same procedure when T4 is suspicious?
ما أعرف شنو قصد السؤال.
قصده إنه بالتي اس اتش بدنا نسوي ديليوشن من نشك إنه أكو
interference.
انترفيرنس. واي بالتي 4 ما نسوي هذه البروسيجر؟ من نفس الشك موجود بالتي 4.
very small amount. ما you can't do dilution. very small amount.
دكتور قصي كان رافع ايده، فتفضل دكتور قصي تسأل سؤالك. دكتور قصي ويانا؟
اي نعم العفو دكتور انور. لا بس I have a comment. يعني as like Professor Mahmoud and Professor Ghassan said, however in one review يعني TSH were normal in more than 80% in patients with central hypothyroidism. One small review
in isolation.
Yes, not in isolation, no, in a patient with central hypothyroidism.
عفوا تفضل يا. All right, go ahead.
And this can be explained in part by the secretion of TSH. However, they use a cutoff of 3.5 TSH to define as it is normal. In this review, I will send it later. I have no the article now not in my hand. However, they use a cutoff of 3.5 to define that TSH is normal or high. يعني 0.2 they define 0.2 as a cutoff for low TSH and 3.5 as a cutoff for high TSH. So they found that 80% of patients were in the range of 0.2 to 3.5. In a small review, as I remember, about 50 patients.
Yeah.
Dr. Qusay, this is expected. And we teach people, usually the TSH can be normal, or can be low, or can be high because of biologically inactive, but immunologically active. هاي انت اللي كاتبها حضرتك، فانا اعتقد اكو بها مشكله. TSH can be normal, high or low. بس الكومن ستوري هو normal or low. مو هيك دكتور قصي بالك؟ نعم. بس دكتور عيسى سائل سؤال دكتور انور، يمكن لو تقرا السؤال.
اي بعدنا استاذ. اوكي. Can central hypothyroid presented with slightly decreased TSH and normal T4 and T3, especially in the early period? استاذ غسان.
With the slightly decreased TSH, normal T3. I'm trying to read this one. Yeah. So the T4 doesn't change at all?
Only TSH.
هو احنا عادة عليها بعدها ما تنطبق عليها سنترال، ما تنطبق عليها سنترال هايبو.
هو احنا ونعم استاذ احنا بالسنترال ندور الفري تي 4 ما ندور تي 4
بالضبط. حتى الوقت روح قبل على سؤال دكتور رافد نفس تقريبا هم قريب عليه بريجننت.
يعني قصدي عفوا مهمه يا تفضل. انا اقصد
اوكي استاذ
يعني انه البيكتشر راح تشبه السب كلينيكال هايبرثايروديزم.
لا نورمال تي 4 تي 3 طالع وديكريز سلايتلي ديكريز تي 4 اس اتش.
هو استاذ غسان احنا عاده
اسمحوا لي سب كلينيكال هايبرثايروديزم. That's not reported.
بس احنا عاده بالسنترال هايبوثايرويد we need free T4. اي
Yeah, you
مو
need to have
مو توتال.
yeah. So
دكتور
it should
غسان هو
not.
اليوجوال ستوري in graves you will have suppressed TSH mildly suppressed with normal T3 T4 هاي early 3 month or 4 month of graves. احنا ندخل ترى بطريق كلش طويل. هو سؤال يقول
طبعا هي
central hypo ممكن يجي كل شيء وارد، بس يعني انت شو راح الشخص central hypo و TSH mildly elevated و T3 و T4 normal، هاي مثل ما قال استاذ غسان هاي تروح نحو الجريفز سب كلينيكال جريفز اكثر، سب كلينيكال هايبر اكثر. فحتى لا يضيع الوقت يمكن سؤال دكتور رافد او كل كان يقول اذا central hypopituitarism how you treat thyroid in that lady
in pregnancy استاذ دقيق in pregnant و central hypothyroid how treat و how follow up.
احنا طبعا في كل الاحوال نتابع الفري تي 4 او التي 4 وما متفق ماكو اتفاق تي 4 لو فري تي 4 هاي احنا ويا استاذ غسان اختلفنا بها.
لا حسب
يعني ما عندهم باستراليا توتال تي 4، احنا بالعراق وي بليف توتال تي 4 مور ريلابل بريجننسي
حسب الموجود عندك استاذ. الموجود عندك انها توتال ولا فري. التوتال موجود عندك you aim for a high normal T4 levels. جست خلي التي 4 على الجهه العاليه، حتى لو صعد عندك شويه فوق العالي ما راح ياثر على الفيتس. اوكي 1-2 points above normal لا تخاف يعني ابدا، ماكو مشكله. So you aim at high normal. وبالمناسبه يعني حتى من المريضه ما عندها central hypothyroidism when you replace thyroxine you aim at high T4 as well. Okay. Anyway go ahead.
ودكتور بريسك يقول how frequent.
استاذ انا راح اعزل اعطيك اياه
لا مو احنا نريد، احنا بالستة نريد نمشي
ان شاء الله استاذ. اوكي دكتور بريسك يسأل how frequent we may face isolated secondary hypothyroidism.
عنده شوف السؤال how to what
frequent
يعني هو frequent الفريكونسي of isolated
secondary or central. I can't remember one case that I've seen central isolated. We see isolated ACTH deficiency more common nowadays. حتى قبل كانت نادرة لأنه الآن نستخدم immune check inhibitors very high frequency وهذا اللي يسوي الهايبوفيسايتس وما أعرف إيش with a predilection for ACTH destruction. بس isolated TSH deficiency very unusual ما مر علي الحقيقة. ما أعرف إذا أحد من الزملاء والأخوة الحضور الأساتذة مر عليهم isolated with يعني post surgery bad luck. ممكن يعني السيرجن أخذ في الشيء ثارتروف فيها بالطريق، لكن إنه ماكرو أدينوما وتسوي TSH in isolation destruction very unusual ما مر علي الحقيقة. أستاذ عباس شو تقول؟
نفس السؤال يعني difficult. احنا بصراحة بالبراكتس we go for cortisol more dangerous in hypopituitarism than thyroxine. فما نعالج الكورتيزول deficiency يلا بعدين نفكر بالهايبو. بس احنا ما عندنا awareness how frequent we see only pure TSH deficiency بس rather than TSH with cortisol. Very unusual. بس ما منتبه له والله ما منتبه له. Very nice to look for the future.
Okay. Another question. Could you kindly favor explain how to interpret the result of TSH after BEG precipitation?
حقيقة هذا موضوع الكرايو يعني موضوع البي تي اس اتش بي اي جي بريسبيتيشن موضوع جديد وماينر برنت وماكو داعي نضيع وقتنا به. شو تقول دكتور غسان؟ هذا فيري ديفيكلت. احنا البي اي جي استخدمناه فور ماكرو برولاكتين، انه فور ماكرو تي اس اتش هذا ماينر برنت، واذا بدينا به نخلص بال10 بالليل. يعني هذا فيري ديفيكلت. هذا دكتور حيدر اياد عندنا بالبصره قاعد يشتغل عليه. هو اي واحد يشوفه تي اس اتش ان ابروبريت يسوي له بي اي جي، ذبحني شلع قلبي دمرني. خلص البي اي جي مالتي انا حاط البي اي جي على مود الماكرو برولاكتين هو قام يستخدمه للتي اس اتش دمرني.
لا يعني تطلع عندك قراءات خاطئه بالمناسبه. يعني هذا المريض ما وقفت عليها يعني هوايه مثل ما قال استاذ عباس، لانه البريسبيتيشن كانت تقريبا 50% وحده من
دكتور حيدر عنده انترست. دكتور حيدر اليوم ما موجود لسبب طارئ، ان شاء الله على المستقبل يحل لنا اياها، بس لا تدخلونا في تفاصيل ماينر برنت.
استاذ عباس قال بالستة نخلص، فان شاء الله نشكر الجميع ونشكر
شكراً
جدا
جزيلاً.
استاذ غسان على هذه
أستاذ
المحاضره
غسان.
الرائعه جدا.
استاذ غسان الشكر ما يكفي، يعني الشكر ما يكفي.
جدا ممنونين. نعم اي والله استاذ.
والله يعني موقفك اول عراقي نحس به عنده ريح عراقيه يعني وامانه، رغم ايش قد دخلنا محاضرات يعني دائما محاضره 10 15 ويوقفون.
اقول لك استاذ اول عراقي قلبه علينا.
اي والله. لا ودكتور انور بصراحه يعني كلش حريص وامين، والرجل يعني يجمع الله يعني لو ما دكتور انور بصراحه يستمر بها الاخوان كلهم شوفهم راح. ايوه وعجبي يعني هواي يروحون ماينر برنت، هواي يسالون، كلش رائع يعني وصلوا مرحله كلش زينه يعني. هذا فالشيء وصلوا مرحله تجاوزوا كل الحدود الحمد لله. يعني هاي المحاضره كلش تفيد
والله استاذ. وحضرتك لك نكهه بالوجود بيوم اللي نشوف حضرتك ما موجود مع النواحس.
الله يسلمك.
شكرا جزيلا استاذ غسان. شكرا جزيلا.
شكرا جزيلا. الله
يحفظك.
مع السلامه. شكرا مع السلامه. مع السلامه.
شكرا للجميع الحضور وشكرا جزيلا.
السلام. الحمد لله.
استاذ غسان اولا ممنونين ورحم الله والديك، وثانيا حتى احفظ التسجيل هو هسه اوكي ريكورد لاخر لحظه، فبس اطلع له شلون ينحفظ؟ استاذ غسان تسمعني؟ استاذ غسان؟
دكتور انور اتصور ينخزن على الجيميل.
يعني راسا هو حينخزن على الجيميل
اتصور ينخزن. اتصور ينخزن على الجيميل.
اي مو انا المشكله هو كتب لي يعني حاخزنه بالاي كلود، بس انا اعتقد الاي كلود مالته مقبض فما اعرف.
ما اعرف والله بالضبط. بس اتصور يقول ينخزن على الجيميل اوريدي.
اذا احد من الزملاء عنده فكره بس انهي المحاضره. شكرا دكتور برسك.
يا اهلا وسهلا. شكرا جزيلا لكم. عاش ليدكم.
شكرا جزيلا. ممنون ما قصرت حبيبي.
مع السلامه.
مع السلامه.